when you build one of these systems, models. Coefficients of the extent to which one thing affects the other. And he had a diagram like this with coefficients on it. And I said, where do those coefficients come from? And he said, ideally they come from a systematic review of research on the effect of neighborhood income on the physical activity infrastructure, or the effect of household income on school attendance. If we can't get a systematic review to get that coefficient, we find one study. And if we can't do that, we find something close to it and hope it's not too far, that was studied, and hope it's not too far away, or we just make something up and do a sensitivity analysis on it. And I said, so when it gets down here, well, he had an actual disease at the end. I said, so that coefficient where BMI affects cardiovascular disease, that would be a review of epi studies, right? Yeah. I said, so what the epidemiologist traditionally defined as doing, in essence, is helping provide one of the coefficients you would put on this. But someone who doesn't self-identify as an epidemiologist would be doing the research that provides another coefficient. And he said, yeah. And he said, this is why he's self-identifying less and less as an epidemiologist. And to me, in this broader enterprise, it's a noble calling to spend 5 years getting the grant money, 4 years collecting the data, 3 years writing it up, to provide one row on a meta-analysis that's going to perhaps become a hopefully not too far off coefficient on somebody's diagram like this. I wonder, are Sandro and Curry saying, no, forget the study of E&D. Now, part of this is that risk factor epidemiology has reached its limits. People were saying this even back in the 90s. We've already found all the things, Graham called it, we've already found all the causes of cancer. I was writing this in like 1998. Time is like to take action. Forget looking for new risk factors for cancer. This was before HPV was recognized as a perhaps universally necessary cause for one cancer, before H. pylori was recognized, and for other outcomes before a sleeping position of your little baby was a major determinant of sudden infant death syndrome. I've been hearing, oh, all the big effects have already been found. We've got the low-hanging fruit. Let's just go to policy. Risk factor epidemiology has reached its limit ever since I've been in this field for 40 years. And I haven't seen the evidence that it's reached its limit or that we've picked all the low-hanging fruit. And I don't find it hard to come up with counterexamples, yet that's a big element. So, those are my thoughts on causal architecture. Now, what they call population health science. Now that you can get a degree in population health sciences, there are other books on population health science. Sandro and Curry seem to be adopting this term to mean they have their own meaning for it. And this is a very recent, this is the first installment of the new series that Sandro is going to edit, and the initial paper is by him and Curry, that's okay. And it's about population health science. Now, fortunately, in a page that's so early in the book, doesn't even have a page number, we have the 9 foundational principles of population health science. And we have 9 minutes to go through them all. Well, I'm sorry. Number 1, population health manifests as a continuum. Jeffrey Rose wrote of sick populations and sick individuals. Populations either sick or not sick. I don't think he meant it was a binary thing. Very unobjectionable. The causes of differences in health across populations are not necessarily an aggregate of the causes of differences in health within populations. This is directly from Rose. It's one of his key ideas. He put it much more simply. The causes of incidence may not be the causes of individual cases. And causes of individual cases may not be the causes of incidents. I think there's a long overdue critique of this idea. I personally disagree with this profoundly, but I'll just say that. Let it go on, because we have 7 more. Large benefits to population health may not improve the lives of all individuals. This, as far as I can tell, was an overlooked element of Rose's thought. His idea was, what, the paradox, I guess the prevention paradox. We don't target, we apply interventions to everyone. Only some of them will benefit. And so we all need to wear a helmet, even though when we ride our motorcycle, even though only some of us are going to have our cranium protected in a crash. A crucial element of public health. I think that's what public health is all about, and a very important idea. But what about disparities? There may actually be another bullet here that addresses that, but in case it doesn't, I'll say it now. If you follow Rose, chapter and verse, you may worsen disparities. If you would do things that are going to be not targeted interventions, and they're going to benefit perhaps maximally and efficiently, whatever, the overall population health. You may make disparities where minorities are getting the short end of the stick, economic minorities, racial minorities, cultural minorities, ethnic minorities, and other educational minorities. You may actually worsen those. I haven't been able to find that anywhere in Rose. It's clearly in everyone's consciousness. It's embedded here in population health science as Sandro and Kerry are conceptualizing it. And I think they'll never, there's Rose idolatry out there, which is fine. I'm passing around dog-eared copies of Rose's book is a time-honored thing among students. We used to hand around William Ryan's Blaming the Victim. I think you all should get your hands on a dog-eared copy of that one too. It's a good thing, but that doesn't mean it's perfect. And I think what we're seeing here is a recognition of a crucial thing that was missing. The importance of disparities. And that a pure Rosian approach may improve overall health, yet worsen disparity. Causes of population health are multi-level, accumulate throughout the life course, and are embedded in dynamic interpersonal relationships. Hard to argue with that one, except for the accumulating part of it, for me. Some causes of population health operate only at certain times of life and don't accumulate. But with that small quibble, hard to argue against. Small changes in ubiquitous causes may result in more substantial change in the health of populations than larger changes in rare causes. This is Rose chapter and verse, and for those interventions where everything else seems to make them indicated, it's a good thing. And so if the exposure is widespread, even though the effect in an absolute sense may be small, you may have a major public health impact because so many people smoke, for instance. The magnitude of an effect of exposure on disease is dependent on the prevalence of the factors that interact with that exposure. Well, this is straight out of Ken Rothman, 1974. So even the Bête Noire had something good to say. A real emphasis on interaction. I asked Sandro after his talk, and one of the things you're saying is we should be doing a whole lot more of interaction and effect measure modification analysis than we are today. And he said, yes, absolutely. That is a take-home message from what we're saying. And I said, and mediation analysis? He goes, so he was preaching to the choir on both of those things for me.
I still don't see why this fits into population health. So yes, that's like a methodological, known, right? So why is this,
Well, for me, again, I can't, I'm treating it like a Rorschach plot, which is just fine, I think. one of the key places it fits in is when we look at disparities. So you're not going to be able to know that there's a bigger impact on blacks or the less educated or whatever unless you study those interactions. If it's overall population health and intervention and what's it going to do to your ultimate outcome, maybe you don't care about the black box in between, maybe you do. They certainly do. A lot of people don't. And you wouldn't care about those interactions. But to me,
Yeah, but that's
if you
not
want to study
saying-
disparities, you're studying interactions.
I would argue that that's not saying that. That's talking about sort of the magnitude. If it was stated the way that you just stated
okay.
it, I would agree, yes.
So here on disease,
Yeah.
we're filling in an ellipsis on the overall total population rate of disease,
Yeah.
as opposed to what I was saying, which is disparities.
Yeah.
I see your objection. So yeah, maybe they would want to edit that. Or
Yeah.
Prevention is often better than cure. Well, I think that's Public Health 101, isn't it? That's what drew me into public health. I read a sentence in a paper. One sentence, one paper. I read it in January of 1973. I can remember the moment I read this paper. If there was a mirror, I would have actually seen the light bulb go on over my head. And it said that it was by Warren Winkelstein and a colleague, published in 1969. He came to visit when he was still alive, and I got him to sign. I told him the whole story, got him to sign a clean copy of this. He was so embarrassed. I could see him, the look in his face, all the good I've done in this field might have been outweighed by bringing this guy in. No, and that sentence was, the evidence supports the hypothesis that the health status of a community is largely independent of the quality and quantity of medical care in that community. Well, that's pretty strong. But there's more to health at the population level than medical care. Of course. Why didn't I think of that? You can get a degree in this public health. That's what I want to spend my career doing. That's what number 7 is saying. Number 8, efforts to here we go. Efforts to improve overall population health. Maybe a little bit. May place some groups at a disadvantage, I would say. Whether equity or efficiency is preferable as a matter of values. To me, this circles back to number 3 and is the sort of disparity supplement to a undiluted originalist Rose kind of view. It's bringing the concern about disparities into this. And then finally 9, we can predict health in populations much better than we can predict health or disease in individuals. This is one of the points that Bev Levin, when she published these views, she was Bev Rockhill, graduate of this department and former faculty member here, that most people, women who get breast cancer, don't have any of the risk factors for breast cancer. The leading cause of death, most men who dropped dead from a heart attack didn't have any risk factors for myocardial infarction up until the time they did. So we're actually better scientifically at seeing what is going to happen at the population level than we are with individualized medicine and send me your blood sample and I'll tell you what your genotype is. And this individuated, privatized thing that is certainly around. It's in the medical area. Sometimes it seems to encroach into public health, but it's really anathema. So, and it's a tenet here. So, I only have quibbles with the items on here. And this is what they're thinking of as the science that does this is public health science. I see this as policy analysis, public health policy analysis, and the epidemiology feeds into that. Sometimes I wonder if they might be, sometimes, attempting to redefine epidemiology as public health policy setting and analysis, or whether they're just saying, let's pay more attention to the role of that in that realm. Yes, good.
What's the issue with number 8, though? I mean, at least in my education as a public health, like national public health, the core value of public health is equity.
Yeah.
And this seems to be leaving it open to, I don't know.
Well, what they're saying, I think, is, and I've read, of course, the whole book by now, got it 3 months ago, equity and efficiency sometimes can be at counter purposes.
Yeah.
You can improve the overall health by a measure that's going to make a disparity worse. So you will then, well, they say it's a matter of values. I would say it's a matter of ethics, but something to be addressed is when one measure would improve overall health but make a disparity worse. Another measure might make a disparity worse but not improve overall health as much as the first one would. They're pointing out that sometimes these two these two desiderata, right? We want to do things efficiently and have the biggest effect on the one hand, but we are worried about disparities as well, that these sometimes can clash. That's my view. It's easier to agree with it when you look at it that way.
So this reminds me of my background from biochemistry, and so this reminds me a lot of sort of the revolution that took place in the biosciences as well, where also in the late 90s, early 2000s, where systems biology came about. And until then, biology was very much experimental biology at the, molecular level or the biochemical level. And I think when systems biology came about, there were people who were, wondering, like, what is this if you're looking at it from such a macro level and trying to take such a systems approach, because that's just not how we did.
Well, and was it the case where, analogous to here, there were coefficients on those systems that somebody needed to do that study to fill in?
Absolutely. And I think that...
So it shouldn't be an either or, it's let's do this as well.
Yes, exactly. And I think people are... Now there's a lot more integration of, well, you need sort of the basic science and the zooming in order to get the details to be able to zoom out. And I think a lot of that is contingent upon the technology that's been developed. The instruments have gotten better at measuring whatever parameters you're interested in, which you couldn't do before. And then also the ability to collect data faithfully and to collect data well, and to also be able to analyze that, because you can't take a systems approach unless you have proper data from all the different factors that you're analyzing. And a lot of that does come from, field work or your wet lab research. So this reminds me a lot of that, because I think you do, I think epidemiology can still stay its discipline while also accommodating a systems level.
Yeah, and that's one of the reactions I had in the 90s, and now it's like, well, actually, I think there should have been less genetic epic, but that's right. Instead of doing this, throw it out, do this, let's add this. So you see an analog in systems biology to what I'm seeing as this causal architecture, and I'm thinking of it as public health policy analysis, and that's the system. And I'm thinking of the studies that are going to provide the coefficient on one arrow as a different but necessary thing, and so is Dan Tabor. And I don't really care about TERF and how we self-identify, but somebody's still going to need to do those studies that provide those coefficients. But it can't hurt, and it can only help to be thinking about and talking to the policymakers and the systems analysts so that the results we produce will be more useful in that realm. And we have a young faculty member, just got tenure, I understand. This is his career goal. Daniel Westreich wants to make EPI more relevant to policy. And he's not just thinking about it in the abstract. He's talking to policymakers and the systems analysts and the people who actually have policy choices they're struggling with, and saying, how could we do our studies or analyze the data even from our studies in better ways to serve that purpose? Yeah, Alice.
So I just want to say that this is true, and I think that modelers know this, and I'm sure that Sandro also was thinking about this too, the fact that for when these models are developed, we are missing many of the parameters that are really required to address these questions. So that's one thing, but I also want to say that I think there are structural problems in the way that this research is getting funded. So for example, the MIDAS program through the NIH, which is funded by NIGMS, that program, they are funded to do these kinds of complex models to address infectious disease problems. However, they are not allowed to collect any novel data in response to those funding RFAs. So you end up with a group of people who have the tools to be able to answer these questions, but don't have any of the information or parameter estimates to be able to fully answer those questions. So I think that's a perfect example of the issue that you take with this, in that we need to be working together in order to really address these questions properly. And so we need to be thinking about, I think, in terms of training our epidemiology students in both understanding that there is this process of coming up with those parameter estimates, but there's a process of understanding how these models work too, and the best ways to get those estimates for these models will help address these more complex questions in the future.
Well, as with the old debate in the 90s, the more I studied it, thought about it, talked with folks about it, the less kind of against it I was. Principally, fractals, it was there, and it was promoting social equity. I hope that worked at least to some extent. A lot more progress. And here, the more I read, talk, and the input I just got today is the last input I'm going to get before I write this commentary that was due at the end of August. And I'm warming up more and more to what Sandra and Carrie are saying. You've actually helped me be more charitably disposed toward it, and I have to stop now. Not only are they hounding me for this thing, they were expecting a hard-hitting critique that said that Sandra and Carrie are all wet, and I'm not going to be doing that, and I'm going to blame you all. Thanks.